Hello and welcome to today's webinar featuring David Mandell. I'm Claire Cameron, Engagement Editor at Spectrum, the home for autism research news and analysis. We'll begin the presentation in a moment, but first, know that we'll be fielding questions at the end of today's presentation, but you can ask them at any point during the session. To ask a question, submit them via the chat window to the left of your screen. And as always, I'll note that if there are any members of the press tuning in, you can only report information presented during this webinar if that material has already been published elsewhere, or if you have first obtained express written permission from the presenter. Professor David Mandell joins us today from Philadelphia, where he is Professor of Psychiatry and Pediatrics at the University of Pennsylvania and Director of the Center for Mental Health Policy and Services Research. In addition to his work at UPenn, Mandell is also Associate Director for the Center for Autism Research at the Children's Hospital of Philadelphia. He completed his Bachelor of Arts in Psychology at Columbia University and Doctorate of Science at Johns Hopkins School of Hygiene and Public Health. Professor Mandell's research focuses on state and national level services for people with autism, as well as experimental studies designed to determine the best strategies to implement practices in community settings. Welcome, Professor Mandell.
Thank you. It's very nice to have this opportunity. I will say that it's a little more nerve-wracking when you're giving a presentation to your phone and you can't see everyone, but I'll still do my best to be interesting and try and be responsive to the questions and comments at the end. So I would like in this presentation to talk about some of our research on policies that have been passed in the United States and their effects on individuals with autism. And then I'm going to make an argument based on the work that I've done with my group in schools that we have some missing links in how we conceptualize policy for children with autism and also other people with disabilities that we can fix by having a more precise understanding of what the gaps, the service gaps and needs are, and being more precise in targeting those policies. So we have a long history in the United States of passing policies that affect individuals with autism, starting in the early 60s with the Community Mental Health Act, which was the first time that we started to create a national and structured system in the United States to move people out of institutions into the community. Many of those people that we were moving out were people with psychiatric and developmental disabilities, and though we don't have a really good count, I'm sure it also included individuals with autism. In 1965, we passed Medicaid under the Johnson administration, which was the first time we had anything related to universal health care coverage in the United States, and I'm going to talk a little bit about how Medicaid has affected care for individuals with autism. Probably the most important entitlement that children with autism have started in the mid-70s with the passage of the Education of All Handicapped Children Act, which entitled all children to a free and appropriate public education. And in 1990, when it was reauthorized as the Individuals with Disabilities Education Act, was the first time that that children with autism were counted separately within the education system, which had a lot of important implications. And you can see on this slide a list of policies that have affected how we care for infants and toddlers, how we think about employment and housing for individuals with disabilities. Two of the ones that I'll focus on most specifically are the Medicaid autism waivers, and I want to talk for a minute about what those are for those of you who are unfamiliar with them. Each state has an agreement with the federal government to provide public insurance through Medicaid to individuals who are impoverished or individuals with disabilities, and the feds match the dollars that are spent by the states, in return for which the states have a certain set of services that they are required to provide to individuals who are Medicaid enrolled. A state can say to the Center for Medicaid Services, I have a group of people that if I don't provide a special set of services to them, they are at very high risk of being institutionalized. And a fundamental function of Medicaid is to keep people served in their communities. And these may be people who have who would otherwise be eligible for Medicaid, but the services they need aren't covered in the state's Medicaid plan. Or it could be individuals who wouldn't otherwise be eligible for Medicaid because they make too much money, but because they're at such high risk of institutionalization, the state can expand Medicaid coverage to that group. And so far, 11 states have passed autism-specific Medicaid waivers, meaning that individuals with autism, regardless of their income, can be enrolled and receive Medicaid reimbursed services. And that's had a lot of important implications. Then there are many other states that have Medicaid waivers that serve individuals with developmental disabilities more broadly. And for many of those states, most of those states, autism is a covered group within those waivers. The other policy that I want to talk about that has received a lot of attention in the last few years are the autism insurance mandates. The autism insurance mandates have been passed state by state because in the United States, insurance laws are set for the most part by the state, with some important exceptions that we'll discuss. And you can, in 2001, Indiana passed the first autism insurance mandate. And if this slide were working the way that it was supposed to, you would see other states begin to light up, showing each of the states that has passed the mandates and in which year. So Indiana, so I apologize for that, but 2001 was the first mandate that was passed in Indiana. The next mandate wasn't until 2008. And we now have 45 states that have passed mandates saying that private insurance companies are required to provide health care coverage for individuals with autism. And they vary in the age range that they cover, and they vary in the dollar caps. But at the heart of those services are autism-specific community-based services like applied behavior analysis, speech therapy, occupational therapy, physical therapy, diagnostic and assessment services that often commercial insurance plans explicitly exclude. Now, these benefits are available to people who are enrolled in commercial insurance plans that are covered by state law. So that means large employers with more than 50 employees, and employers who use commercial insurance. These benefits don't apply to individuals who work for companies that are self-insured. So that's many large insurers, places like Home Depot or Discovery. Some of those places actually have elected to have benefits that mirror the state insurance mandates. Many of them have not, and it also doesn't apply to small businesses for the most part. And that gives us a chance to compare within states what happens to individuals who are enrolled in commercial insurance plans that are subject to the mandate and insurance plans that aren't subject to the mandate. And we can also compare both those groups to individuals who are in states that don't have a mandate or didn't yet have a mandate when we were able to obtain their data. So we partnered with the Healthcare Cost Institute, which combines insurance claims information from 3 or 4 major insurers in the United States, which gives us access to information about almost 100 million people in the United States. And we can look at how individuals who are covered by the mandate fare relative to individuals who aren't covered by the mandate. Now, insurance companies were really concerned about these mandates. They were concerned for 2 reasons. One is they thought that people would just sort of come out of the woodwork diagnosed with autism, and you would see an increase in the number of individuals diagnosed with autism receiving commercially insured reimbursed care. And the second thing is they thought that whatever the cap was on what the annual cost could be on the mandates, that you would see everyone using spending up to the cap. And so I want to show you a little bit of data we have from about the mandates and what their effects were. So on this slide, you see, well, does it increase the number of individuals diagnosed with autism who are served by that commercial insurance plan? And what you see is that in non-mandate states, it's about the prevalence, the treated prevalence of autism, so how many individuals diagnosed with autism are in that commercial insurance plan, is about 1.6 or 1.7 per 1,000. So far below what we think of as the community prevalence. If you believe the CDC number of 1 in 68, that would mean that we should see 15 individuals per 1,000. And what we find is that after the mandates pass, in the first year post-mandates, you see no difference between mandate and non-mandate states. But then over time, you see an increase, so that 2 years post, you see 1.8 per 1,000 as opposed to the 1.6 per 1,000. And 3 years post the implementation mandate, you see a slightly greater increase. So it turns out the mandates do result in more individuals with autism being diagnosed and served in commercial insurance. That's good, but still far below what we think of as the community prevalence. We could also ask, among those individuals who are diagnosed with autism, does it make any difference in the care that they receive? And one of the ways we can measure care is by how much is spent on what we might think of as ASD-specific treatment services. So again, those are those ABA services or the neurodevelopmental therapies like speech, occupational, and physical therapy, or mental health services. And we see that it makes a huge difference. So what we're observing here is monthly spending, and 1 year post the passage of the mandate, you see that the average expenditures for kids enrolled in the mandates is $250 versus $150 for children who are not eligible for the mandates. 2 years post-mandate, that goes up to almost $300, and 3 years or more post the mandate, it goes up over $300 per month. So that's really a substantial increase in spending. And if you think about the estimates people have given about what a good behavioral plan for individuals with autism looks like, people have estimated anywhere between $22,000 and $40,000 a year. So these dollars don't approximate that amount if you multiply them by 12, but if you combine them with the services hopefully these kids are receiving through the early intervention system or through schools and other sources, you might imagine that this makes a substantial impact on the type of care that they might get. I want to point out a couple of things. One is, I think one of the reasons we see the spending going up in later years post the mandate is that states were really unprepared and didn't have the capacity to provide this care. There really wasn't enough supply of providers, and it took a while for the market of providers to increase. And the second is we talked with many insurance companies, and some of them I think were doing what they could to deny services. Other insurance companies didn't know how to bill and cover these services. They didn't know what licensure and credentialing processes should be like. They didn't know what reimbursement rates should be like. And so it has taken a long time for these mandates to have their intended effect because the groundwork wasn't laid as well as one might hope. In states where the groundwork was laid a little better, like states like Massachusetts that was already paying for ABA, that you can see that the implementation of the mandates had a much larger effect much more quickly. We could also ask, who did these mandates help? One possibility is that you see a lot of kids with autism who all start to get more services. The other possibility is you might see kids who had high need really being more of the beneficiaries of these mandates. And we find that the latter is the case. So if you look at the graph on the left of your screen, what we did is look at how much money was being spent on these kids in commercial insurance prior to the mandate, and we looked at what percentile they were in. Were you in the 5th percentile of spending, 15th, 25th, 35th? And then we looked post-mandate how much of that additional spending really accrued to that particular group. And what you see is that for outpatient services, a lot of that spending accrued to those who were already in the higher percentiles of spending. In fact, there really was no increase for those kids who were sort of on the left side of the distribution. That is, kids for whom there wasn't a lot of spending to begin with. And I think one way to interpret these findings, and we need to do a lot more work to make sure we fully understand them, is that kids who had very high need were the ones who were the beneficiaries of the mandates. And this became an important supplement to the dollars that were already being spent on them. Another way to interpret this, and one that we also need to explore, is that insurance companies have still managed to keep the bar relatively high for people to access services. That is, they still may be making it difficult for families to access services. And so if your kid either doesn't have a lot of service need, or you're a family with not a lot of resource or not as capable of advocating for yourself and your child, you may not have benefited from those mandates. If you look at the slide on the left, that's that same graph by percentile spending for inpatient spending. And one of the things that we see is that inpatient spending doesn't really increase as a function of how much money was being spent on you to begin with. And that's unusual. Most of the time when we do studies like this, we see that kids who use a lot of services in one area use a lot of services in another area as well. And this is very encouraging because I think it suggests that the mandates are having their intended effect of increasing care in the community and not resulting in a lot more kids using inpatient services, for example. Now, the spending that we see in commercial insurance is dwarfed by the spending that we see in Medicaid for individuals with autism. So this is a study that Doug Leslie's group at Penn State did, where they compared Medicaid and private spending in a couple of different years. And what you see is that on average, outpatient spending for individuals with autism was $20,000 a year, compared with $3,000 a year or $3,500 a year in private insurance. And this is, I think it suggests that when we think about policies that affect children with autism, as important as those mandates have been, there's been a lot of energy that has been going into to those private mandates. And just so you know, given the current political situation, if commercial insurance is opened across state lines so that you can buy, so that state laws no longer apply to insurance products, those mandates will be in peril. And that's really important. Perhaps even more important for individuals with autism is that the proposed changes to Medicaid in the United States could have a dire effect on spending, healthcare spending for individuals with disabilities, including individuals with autism. State Medicaid policies the covered services have traditionally been very generous relative to commercial insurance and very creative. They've allowed for spending on things like one-to-one support in the community or durable goods or transportation, other things that improve functioning and quality of life, as well as things that are direct medical care to individuals with autism. And we could see all of that go away. Our research has found that the more that is spent in Medicaid, especially through the Medicaid waivers, the greater reductions we see in inpatient hospitalizations and long-term care for individuals with autism. Doug Leslie and our group had a really nice paper that came out in Medical Care recently showing that the more generous a Medicaid waiver is, the greater maternal labor force participation is. So we had published work before showing that mothers of children with autism are very likely to drop out of the workforce when their children are young. It turns out that when a Medicaid waiver is available to them, that labor force participation decrease doesn't happen to the same extent. And the other finding we have recently, which has just been submitted for publication, is that we know that there are a lot of racial and ethnic disparities in need for individuals with autism. We see that African American families traditionally report more need, have fewer services available to them, and when Medicaid policies in a state are generous, you see a lot of that disparity go away. So this is a really important program for individuals with autism. Now, I want to show you the specifics of one study we did of this program. So we wanted to see whether this was, and this is the finding that I mentioned just prior, does the spending on Medicaid result in a reduction in what we might think of as unwanted outcomes for individuals with autism? When you're looking at claims data, you don't get a lot of opportunity to examine functional outcomes or the kind of symptom outcomes that we would hope to, you know 5 things about 28 million people. And so you have to be a little creative with how you use those 5 things. Here, what we examined was psychiatric hospitalization. Certainly, sometimes psychiatric hospitalization is warranted. Often it's not. And we decided that on average, if we saw more psychiatric hospitalizations in a given state or program, that was probably a bad thing. And what we found was that Medicaid spending resulted in reduced hospitalizations, but the type of spending, the type of service that was most important was respite care. So if you look at this adjusted odds ratio of 0.92, what that means is for every $1,000 increase in respite service use I had over the last couple of months, I had an 8% decrease in the likelihood of hospitalization. Now, what we might think of as therapeutic services or other outpatient services didn't have an effect on hospitalization. And this led me to think about what's happening, that what we might think of as the non-therapeutic services, the support services, are having an important effect on hospitalization. It turns out that the same is true for polypharmacy. If you receive respite care, you're much less likely to have a child on 3 or more psychotropic medications, right? But why are the therapeutic services not having perhaps some of their intended effect? And this is especially important, I think, in light of the fact that we have a growing body of evidence of interventions that suggests that if we intervene appropriately with individuals with autism, we can see dramatic improvements in socialization, adaptive behavior, communication, and cognition. And what you see on this slide is just a graph of how many intervention studies have been published over the last couple of decades and each year. And you see that number is growing tremendously. And you also see that, especially if you look at the latter years, the effect sizes, that is, how much statistically of a positive impact are these programs having on individuals with autism. When we see effect sizes of 0.8 to 1, those are moderately large effect sizes. That means we can have a pretty positive effect on children with autism. And my expectation would be that if we could do that, then we would see a reduction in things like hospitalization and polypharmacy in the claims data. So why isn't that making its way into practice, or even is it making its way into practice? And I asked one of my doctoral students, Alison Namias, to go to all those studies and pull the data from the control groups. Because one of the things we can think about the control group as what's happening in the community. And we could look at what's happening over time between the beginning of a study and the end of a study and look at that effect size, like how much improvement did we see just over the course of the study in the control group. And what we see when we look at those studies is that the effect sizes are very small. So when we see effect sizes of 0.26 for cognition or 0.15 for adaptive behavior, we start to feel like there's not much gain over time in the individuals who are in the control groups. We see similarly small effect sizes for socialization or communication in those groups. So what's happening that we know how to do this in a university-based lab setting, but we have not been able to translate this effectively into communities so that we see the positive effect of these therapeutic services, or services rather that are supposed to be therapeutic. So this hit home for me when I started to work with the school system in Philadelphia and began to think about how to implement evidence-based practice with them and change policy and practice in a large school district. I apologize for this slide. Again, the word effectiveness should be over that right column, but I began to think about this as a difference between efficacy and effectiveness. When we think about efficacy, we think about how these things are tested in university-based settings. Usually that's because I got a grant to deliver the treatment the way it was designed. If I'm an intervention developer, which I'm not, I develop an intervention and then I apply to the Institute of Education Science or to a foundation or to the National Institute of Health to get money to fund the implementation of that intervention, and I get to test whether it works against treatment as usual. That means I get to hire my own staff, and I get them to be highly trained and supervised. They're generally my postdocs or my doctoral students. They're all a little afraid of me, so they do it exactly the way that I want. If they don't do it exactly the way that I want, I work with them to get them to do it the way that I want, or I fire them. And it turns out, in a lot of these studies, there are many restrictive inclusion and exclusion criteria. It turns out that most review committees don't blink twice when we say that for someone to participate in this study, they have to have a developmental age of 18 months. They have to be toilet trained and have no self-injurious behavior. And then when I compare my intervention to treatment as usual, it turns out that it works better. But this is not what happens in community practice. In community practice, what intervention is being implemented is often not based on the evidence per se. The people who are delivering it don't have the same kind of training or supervision. Sometimes they don't have the same motivation because because last year they were trained in something else and they don't feel rewarded or supported in doing this intervention. They don't get much training in it. And it turns out that if you're a kindergarten teacher, for example, you don't get exclusion criteria. That it turns out that because we passed the IDEA, it's illegal for you to say, oh, you can't come into my classroom because you don't meet certain criteria for coming to my classroom. And that's a good thing, but it means there's not the same connection between how we test interventions and how we, and then the places in which we implement them. So another way to think about this is when we do efficacy trials, we take away context. We take away all the real world things that get in the way of implementing interventions the way that they were designed. But when you think about community practice, it's all about context. It's all about those things that make it challenging to implement interventions the way that they were designed. And this really hit home for me with the first randomized trial that we did with a school district in Philadelphia. We had been partnering with the school district for a long time, and they wanted to figure out how to implement evidence-based practice for their young elementary school students with autism, and they had found a program called the Strategies for Teaching Based on Autism Research Program. The STAR program combines discrete trial training, pivotal response training, and teaching and functional routines with a curriculum. It's great for our classrooms where our teachers often need a lot of support and haven't had a lot of autism-specific training or experience. And they wanted to compare it to structured teaching, which is the program that comes out of North Carolina. That was developed by Division Teach, which actually has a lot of overlap with at least the visual schedules portion of STAR. And what we found, now the way we did this was we enrolled 42 classrooms in the district of autism support classrooms in the school district of Philadelphia, which was all the classrooms that there were. We randomized teachers to receive a lot of intensive training and support in one of those two programs. And they really appreciated the consultation and the training, and they liked their coaches. And we found that when they didn't do the program the way that it was designed, so their fidelity was low, which are the bars that you see on the left, that the average change in DAS score, the differential ability scale, which we could think of as a measure of IQ or cognition, was not different between the two programs over the course of an academic year. But when we look at how they did the program how the kids in classrooms did when the teacher was implementing the program the way that it was designed, you see a really substantial advantage of STAR over the structured teaching classrooms. And that's exciting. STAR is a more involved program with a lot more pieces. We would expect outcomes to be better, I think, than we would in structured teaching. And it turns out that if we can get public school teachers to do the program the way that it's designed with no exclusion criteria for the students with whom they're working, that you can see gains in IQ of almost 2/3 of a standard deviation, 10 points over the course of an academic year. That's very exciting. That's a really positive response. What was very striking to me, however, were the numbers on the bottom. We measured program fidelity on a 100-point scale for each program, and what we found was that the average program fidelity in STAR was 57%, and the average program fidelity in structured teaching was less than 50%. That means that even with a tremendous amount of external support, we were not able to we were not able to help these teachers achieve high fidelity in these programs across the board. And the way that I've begun to think about this is like my old friend Calvin from Calvin and Hobbes. And I think of Calvin as a teacher. And he is pulling his sled up the hill. No one likes to go up the hill. It's hard to go up the hill. And I think of these teachers' lives as hard. They have a lot of challenges facing them. And often what we think we're going to do is we're going to mandate a program, or we're going to train them in a program, and we're going to help them. But sometimes we've not helped them. In fact, what we've done is we've loaded their sled. We have told them, you need to do these evidence-based practices, discrete trial training, pivotal response training, functional routines. You have to pair it with a new curriculum. There's lots of extra training you need to go to now. And don't worry, this is all going to work out, and it's going to be better for your kids if you do this. And we also haven't taken into account a lot of the administrative and other kind of sort of organizational hurdles, challenges, the boulders in front of them that these teachers face. Like, we don't pay teachers very much in this country relative to other professions that we ostensibly hold in esteem. They have a tremendous amount of paperwork. They often have an irate principal, because the principal doesn't know why these kids have to be in their school and why they may have to give over a classroom to just 8 kids when there's already tremendous overcrowding. And as a result, these teachers get very tiny classrooms often. They're really far from the bathroom. They're in the basement. And they often have a lot of adults in the classroom, because one of the way we handle the challenges of working with kids with autism is to give them one-to-one support. And teachers don't go to school to become managers of adults, and they don't know how to handle the staff in their classroom. And this got me thinking that it's not enough to train them in these evidence-based practices. It's not enough to mandate access the way we have with the Individuals with Disabilities Act, or with Medicaid waivers, or with autism insurance mandates, that we need to think about a set of policies that attack more the root of this problem. And certainly the initial challenge we had was access and education as a civil right for people with disabilities. And now I think we have a different set of challenges that we need to address. And one of the ways that we've begun to think about this is to go to other people who study what we think of as important similar issues, and see how what they study and how they study it could be applied to what we do. And one of the things that we thought about is how, what are the kinds of policies, and how do we think about creating an environment in which the use of these technologies, the use of STAR or structured teaching or other things, or what sometimes the business world calls innovations, is less challenging for these teachers. And another doctoral student of mine, Hilary Dingfelder, went across the street to Wharton. I apologize for the sirens in the background. I'm across the street from a hospital. But went across the street to Wharton to talk with them about how they measure this in manufacturing plants, when a manufacturing plant has to retool. And they talk about innovation climate, or the climate for implementation innovation, which is the extent to which the use of a new technology is expected, supported, and rewarded. And I thought, oh, we've got a new technology. How can we think about applying this kind of method to understand what's happening in these classrooms? And what we found was, if you measure implementation climate at the beginning of the year, so the teachers get trained and we ask them, how much do you think the use of this intervention is expected, supported, and rewarded? And they answer us, it predicts how well the teachers are doing the program in May. So that's pretty impressive, that you can measure something in September. All sorts of stuff can happen in the intermediate period, and the more they say the use of this intervention is expected, supported, and rewarded, the more likely they are to be doing it the way that it was designed in May. And so that tells us, oh, when we think about policies to affect use of evidence-based practices in a public school system like Philadelphia, implementation climate should be one of our targets. What drove that home for us even more was this graph of the interaction between climate and fidelity on student outcomes. So the white line on this graph is the high fidelity classrooms, and the red line are the low fidelity classrooms. And we find that when climate is high and fidelity is high, we get the best student outcomes. which is great. So if you see these classrooms over here, this is the high fidelity, high climate group, and they have the best outcomes. The second best outcomes were in the low fidelity, low climate group. So who is this group? Well, we went and we asked them, who are you and what are you doing that you're getting the second best outcomes? And what it is that these are teachers who say, no, this program isn't right for my classroom, isn't right for our school, and we're not going to do it. We're doing something else. They tend to be more seasoned teachers who have a lot more autism experience and are working in really challenging schools. And I think we have a lot to learn from these teachers and should be going to them first before we implement programs district-wide to say, what are you doing that's working and what can we learn from you? As much as we talk about research to practice, we should also be talking about practice to research. These teachers down here are the high fidelity, low climate teachers. So these are teachers who say, use of this intervention is not expected, it's not supported, and it's not rewarded, but I'm going to do it anyway. And you see that the outcomes for their kids are not so good, which means that these teachers may be, God bless them for trying to do these programs, but they may be making an ill-considered decision in their environment, and we need to either help these teachers do what these teachers are doing or try and figure out how we implement policies and practices that move their climate from low to high so that we observe the same positive outcomes in the kids with whom they're working. So the way that we've begun to think about this also is to borrow from our colleagues at Annenberg School of Communication. They think a lot about behavior change. And ultimately what we've realized is what we're asking of our teachers or any practitioner in the community when we have a practice that we want them to do is we're talking about adult behavior change. And that we need to focus more of our work on understanding why community practitioners behave the way they do, implement programs the way they do, or that they don't do. And we learned from our friends in Annenberg that intentions, that is the extent to which your motivation, how likely it is you're going to do the thing we ask of you, is the most proximal predictor of behavior, and that attitudes, norms, and self-efficacy are determinants of intentions. And I will talk on the next slide about what these things are. And that to the extent that our policies, practices, and organizational environment affect these things, that's this stuff over here, they may affect attitudes, norms, and self-efficacy. That your work environment can certainly do that. And the other possibility is that the policy organizational environment moderate the association between intentions and behavior. That is, I can have the strongest intentions in the world, but if my aide is out on disability or I don't have the materials I need, it's very hard for me to act on those intentions to implement things the way that they were designed. So just so you have a sense of how we measure this, we measure intentions, we measure these things very simply. I am willing to perform this particular evidence-based practice. Performing this particular evidence-based practice would be good or bad. For norms, we have injunctive norms. That is, people who are important to me think that I should do this. Or prescriptive norms, excuse me, people who are important to me think that I should do this. And injunctive norms, people who are like me do this. And self-efficacy, if I wanted to do this, I could do this. So we were very excited about beginning to apply this to teachers and think about how it should shape how we support them and what kind of policies would help them. What we found is that we have a big problem in understanding what the behavior is that we're supposed to be asking them about. Often, when we do these kinds of things, we are talking about very complex interventions. So here are the pictures of 5 evidence-based practices for children with autism. All of these practices have many, many moving parts. And we are often training teachers in all of them all at once and asking them to do them all at once. And that's really impossible for somebody to do, or certainly very, very challenging. And their intentions and attitudes, norms, and self-efficacy around different components of those interventions may be very different, right? So what we ended up doing was working with the intervention developers and working with the social psychologists who come out of Annenberg to identify very specific behaviors. or more specific behaviors that comprise each of these types of interventions. What are sort of the common elements of a lot of the school-based and sort of clinic-based practices that we do with kids with autism that we think are most important? When we decided on them, neither group was happy. The interventionists thought we were being hopelessly reductionistic. The social psychologists felt that they were still entirely too vague. So we knew we had done a good job because neither one was happy. And what we decided for our classrooms in these very sort of resource-challenged schools, you need to do 4 things. You got to use positive reinforcement as your main strategy for classroom management and behavior change. And that could be measured as a praise to behavior correction ratio and also use of a token economy. You have to have visual schedules to help kids transition from one activity to another. You got to do one-to-one intervention each day. And here's one of our most beloved teachers in the district who recently retired. Her aide was out on disability, so she's doing 2-to-1. She's got 2 kids. She's doing the best that she can, but the environment is affecting her ability to act on her intentions, and you have to collect data. And now, so then as proof of concept, we went in and we asked teachers, how much do you intend to perform each of these specific behaviors? And what we find is that 2/3 of teachers say that they strongly intend to use positive reinforcement as measured by praise to behavior correction or a token economy in their classroom. About half of them say they plan to use visual schedules. And remember, this is after training in all of these things. 40% of them say they're going to pull kids for one-to-one instruction, like discrete trial training or pivotal response training. And incidentally, after further work, we've realized that the intentions and determinants of intentions for discrete trial and pivotal response training are actually quite different. And 1/3 of them say they're going to do data collection. So if I mandate that they have to do a program that contains all 4 of these, and I train them in it, this may be the rate limiting step. That is, because they don't want to do the data collection or they don't feel it's appropriate, it may be that they don't do any of these other components either. And in fact, we went back just again as proof of concept, since schedules is the easiest thing to observe on a surprise visit. We went back and visited them, and we found that of teachers who said they strongly intended to use schedules, within 4 weeks they were using schedules. 96% of them were using schedules. Only 26% of the teachers who didn't say that they strongly intended to use schedules were using schedules. So we think that these things are highly predictive of whether teachers implement the interventions the way that they're designed, but we think the things that are stopping them from doing those things are very different. So we think that use of positive reinforcement is really about pedagogy. It's that these are teachers who are concerned about bribing kids or setting up contingencies that are not generalizable or unrealistic for the rest of their day. So this may be more about helping them understand what the evidence suggests about the importance of positive reinforcement. Schedules is about resources. Teachers who are happy to use schedules, they don't have laminators or color printers, and they don't have access to the software that allows them to print out the icons that could be used on visual schedules. And so we started traveling. Our coaches now travel with portable printers and laminators so that we can make them in the classroom in the moment. One-to-one instruction is about staffing. We have teachers who are great at PRT and DT, but they don't do it. And they say, I have 12 kids in my classroom. All of them are severely affected with autism, and what do you want me to do with the other 11 when I've pulled this kid for one-to-one? And we've realized if we want teachers to do one-to-one instruction, we first have to train them in center-based instruction, in management of their staff, of their assistants to handle the rest of the classroom, in the use of schedules, and that once we do those things first, we can help them become more engaged in pulling kids for one-to-one intervention, and that data collection is about attitudes, that teachers say every minute that I collect data is a minute that I'm not teaching. And so we've spent a lot of time thinking about how we can minimize data collection as much as possible and still have it be effective, and also help teachers integrate the data collection into activities that they're doing in the moment. So for those of you who are interested, we now really only rely on probe data, and we try and make collecting that probe data as much a part of instruction as possible. So these things that we learned about what drives teacher behavior helped us then go back to the district to think about policy for the policies that maybe could drive teacher behavior. And I give this as an example. I think we could think about it in any domain, any arena in which children with autism are receiving care. So one of the things that we could do is work with the district to mandate the STAR program, which was the program that the district chose after our trial. And by mandating it, it lets them know that use of this intervention is expected. One of the things we haven't done as well within these schools is make sure that the principals are a part of that. And I'll get to that in a minute, but certainly it's coming from the district. We've also mandated competency training, which address some of those pedagogical issues. So if you're going to be a teacher in an autism support classroom or an aide working there, you now have mandated trainings that are directly tied to those 4 evidence-based practices. We also provide a lot of ongoing coaching. We now have a contract with the School District of Philadelphia, so our coaches are out in the field a lot working with teachers in their classrooms, and that helps those teachers feel like they're supported in doing this. Some of the places where we've not been successful, but that I think are really, really important, we're still working on them. One is to have clear evaluation standards tied to the things you want practitioners to do. And often we don't do that. Our evaluation standards are often attached to processes that are administrative processes and don't, like, is your paperwork done on time? Is your classroom neat and orderly? And are you making your way through a particular curriculum, but are not tied to the specific practices that we want? And so we are still working with the district on that. And the other thing we're working on is position security. In a lot of school districts, position security is tied to seniority. We're trying to convince the district that they've invested a tremendous amount in these teachers, and if the teachers are showing high competency in evidence-based practices, their position should be more secure. There are 2 other areas in which we are starting to make progress, and we're very excited about that. One is in creating a community with shared expectations. So being a special education teacher or being a clinician is often very isolating. You don't interact with a lot of your professional peers on a regular basis. And we now use our trainings, our school-wide trainings, more as an opportunity to create shared norms and expectations about what we should be doing as teachers. And we are also starting to explore online and social media approaches to creating that community. And the second thing relates to rewards, which is often the most difficult in a publicly funded environment where pay is not tied to performance in the way that we might like it. And therefore, we are working with the district to think about career ladders for teachers and assistants who show lots of competency, expertise, and enthusiasm for implementing evidence-based practices. Can we create demonstration and master teacher opportunities for them that come with other opportunities? So just to go back to my original point, I think often we think about a policy like passing an autism insurance mandate or a waiver or requiring that schools provide education to children with autism or other disabilities. And we have the expectation that that's going to result in some outcome for the people those groups serve. And what we've learned through our work is that that's not enough, and that we really have to focus on the specific practices that we want to be implemented and make sure that the policies target those specific practices, both in terms of helping the practitioner understand what is expected, how that practice will be supported, and what the reward will be for implementing the way that it's designed. So I rely on a lot of colleagues from a lot of different places to do this research. I'm very grateful for their support. Here's a brief list by the types of data that I showed, and I hope now that we can stop and have some time for questions.
Thank you so much, Professor Mandell. We do have some questions, and we have some time to go through them. So firstly, is there a particular resource that you can recommend for navigating complicated Medicaid systems? Because this is also a barrier to accessing services for many people.
Oh, yeah. So the challenge with with answering that question is that Medicaid is state-specific. There are some federal regulations, but every state has their own process that they've implemented around Medicaid eligibility and obtaining services. And so for the states with which I'm familiar, if there are people who want to email me afterwards, I would be happy to try and talk with them about their specific state. But my recommendation is that almost every state has something like a health law or disability law project. These are generally nonprofit advocacy organizations that work to help people with disabilities get appropriate care, and that you really need to connect with an organization in your state. And I have a list of some of them. All 50 states have them. All 50 are receive some kinds of federal or state funding, and that's the place where you want to start.
We have another question, which is, what are some of the general public health and education policy interventions that have been successful that you've seen?
So I would argue that some of the ones that I've talked about, like the mandates, especially the waivers, IDEA, they have been very successful in increasing access to care and reducing some of the financial and other types of barriers that have interfered with people getting appropriate care. So to that extent, they're a success. I would say that this arena of moving the policy lens from focusing on access to focusing on quality and outcomes is a new shift, and we don't have a lot of evidence, at least in this disability landscape, about what policies are most effective. Certainly within the field of public health more broadly, there are lots of public health policy initiatives that have had tremendous positive effects, like laws around drinking and driving, seatbelt wearing, fluoridating the water, vaccines. There are a number that have had very positive effects. But I think when we're talking about now the implementation of very complex psychosocial interventions, we have a longer road to go.
One more question, which is, can you further define what mandated use of the program STAR entails and how Fidelity is evaluated? And also further to that, what are the consequences for not utilizing the program?
Yeah, that's a great question. So, there's been sort of a no-foul rule for the last few years in the district. So what I mean by that is that what it means that it's mandated is that the district passes out information to teachers and to principals saying that this is the program that we use in kindergarten through second grade autism support classrooms in the district. We are in most classrooms at least once every other week, coaches providing ongoing support to teachers, and those coaches reinforce the expectation that STAR will be implemented in those classrooms. Fidelity is measured through mostly through two ways. One is through teacher report to the coach, and the second is through coach observation. So the coaches spend enough time in the classroom that they can observe the extent to which teachers are doing the program elements the way they're designed. The teachers are also required to keep logs for their students, and the coaches can review those logs and collect Fidelity data that way. We've developed a lot of specific Fidelity forms that I would be happy to share after the presentation if people were interested. Up to this point, the district has been very reticent to have there be specific consequences for not implementing STAR the way that it was designed. We are now discussing with the district about what consequences should look like, even if the consequence is withdrawing the coaches and the material support that we're providing for the teacher, which we are very loath to do, but we do think it's very important to have carrots. It also may be important to have sticks in something like this. And so we are now evolving to the point where we're ready to think about what the negative consequence is for not doing it.
One more question we have is, what theoretical model did you base the barriers to implementation of interventions on?
in the complex slide that I showed with the, I assume that's what you're referring. That was based, right? So that was based on two things. One is the theory of planned behavior, or the theory of reasoned action, which comes out of the health psychology and social psychology literature starting in the 70s. And then we added, so in that model, what we call the organizational or policy environment, they would just refer to as environment. That's everything that's not a psychological construct within the individual. We borrowed from the work of Charles Glisson and Nate Williams, who wrote an excellent chapter on this in a book on dissemination and implementation in mental health that I can share. And we took their model and we expanded it to fully incorporate all of the elements from theory of planned behavior and from the organizational components that they identify.
When you were speaking about bringing context into intervention studies, do you think that it's helpful in some cases to go to the community first that you're wanting to test these interventions in?
So I could have spent the whole hour talking about that. And so let me give the short answer, which is yes. That is, I think that most intervention studies that are done in university settings are proof of concept. It shows that under ideal circumstances, with really great clinicians, we can get a positive outcome for kids. It shows what is possible, but it does not show what is probable. And it's only by partnering with the community before the intervention is developed and then as it's being developed that we can begin to have another sense of the probable outcome of the implementation of this intervention in the community. And since hopefully our ultimate goal is to improve quality of life for people in communities and not just in our labs, I think that should be a crucial part of any intervention development.
We've spoken a lot about how this would work within school-based settings, but if you think about adults in the community who are also looking for interventions, how do you see this as scalable and being able to put into community health centers or other centers that are more geared towards adult population?
Yeah, so I think that there are three areas where this is really critical for adults. One is in community mental health centers and providing them support, and developmental services centers. A second is vocational rehabilitation, and the third is housing. I would say we know almost nothing about housing and how to do this in housing. It is an unknown frontier. I think in vocational rehabilitation, it is very scalable. What we see from the little voc rehab research we have is that adults with autism do really well in voc rehab, better than many, many other groups, although in terms of their employment outcomes. But I don't know that we've tested specific models. And also, if you look at the number of adults who enter that system, it's relatively low, given what we know the community prevalence is. So I think that that's an area that, when I've talked with people who work in voc rehab, they're very interested in this. I think we have some nice parallel models from the intellectual disability world that we can borrow from. And we have a network of community mental health centers in Philly. That's actually where we've started. And one of my postdocs, Brenna Maddox, now has 2 grants to help community mental health clinicians implement programs and interventions specifically designed for adults with autism. And what we find there is a little different. In the preliminary work that she's done, she's found that most community mental health centers recognize their inability to serve this group as a real problem. They want to develop capacity, but they feel very low self-efficacy. They really, even though they're very gifted at working with people with severe psychotic disorders or major depression or crippling anxiety, for some reason bring up the word autism and it really makes them anxious. And so we find that the way we have to consider our training and provide them support is very different than the work that we're doing in the schools, but I do think that the same general principles apply.
Okay, I'm afraid that's all that we have time for today. So a complete replay of this presentation is going to be available on the Spectrum News site in a couple of days. It's also going to be available on our YouTube channel. This webinar is part of an ongoing series, so please check on our site for upcoming talks. The next one is with Deborah Klein, and more will be announced soon. There's also video archives of previous webinars. Thanks again, Professor Mandell, and thank you all for tuning in.